So this is an opportunity for having some queries answered from Professor Leif. Over to Dr. Thakkar.
Hello, Professor. Really nice to meet you. After meeting Professor Nick Van Dyke and again meeting you, I mean, I'm quite blessed to have this meeting. Thank you so much. So, Professor, I would like to know much more about the, talar OCD for the I have seen for the medial OCD.
Yeah.
I want to know further about the lateral OCD. How much have you experienced using episealer?
Yeah. Good question. Well, the lateral side is less frequent than the medial side, but we have had a number of surgeries on the lateral side. The instrumentation for the talus proper is the same as on the medial side. The additional difficulty, if you like, on the lateral side is that you need to get access to the talus. And you can do that in two ways. Either you do a fibular osteotomy, which may by some be considered a bit cumbersome. You need to fix the fibula, you need to put a plate on the fibula usually, and so that adds to the procedure. The other alternative is to do a ligament release of the FTA and the FC ligament, and then using a Hintermann destructor, you can pull the talus anteriorly until it's free to apply the guide for the episealer. And then you reattach ligaments using anchors.
Like routine growth.
Yeah. So there are two ways, and really either one of them works nicely. It's a matter of your personal preferences, really.
I mean, obviously there is no option available in the market for the shoulder lesions of talus. But again, if we ask our own self the question, how the metal will tolerate when there is an articular surface on the opposite side?
Yes, this is a question that many ask and wonder about. My personal experience stems from the fact that I used to be a knee surgeon. I put in a whole lot of total knees. Okay. And in Sweden we do that without the patella button. In fact, 95% of all total knees that are put in our country is done without the patella button. So the cartilage on the backside of the patella articulates against the very same material as we are using. And that works. In fact, the revision rate for the ones without the patella is somewhat lower than the ones with the patella button. They're still both very low. So when we started, I felt confidence that this would work. The hyaline cartilage will stand up, provided that it's not too damaged up front during the operation, and we make a lot of efforts to analyze that in our damage marking report. So from the MRIs, we reconstruct the knee, we assess not only the lesion in the talus or in the tibia and the knee, but we also assess the opposing cartilage. And provided that our cutoff point is ICRS stage 1 or 2 is okay, 3 and 4 is not okay. And so we try to stay away from the 3 and 4s, but the 1 and 2 stages are okay. And now after closing in 2,000 implants, I can say that we have now results to say that this works. Yeah.
And about the longevity, what is your experience about episealer knee and episealer talus?
Well, the talus we have, we do not yet have a 2-year follow-up. But in the knee, we have our first patient is almost 11 years old, and he's still walking. he walks the Marcia Longa in the Italian Alps every year. So no, he's up. It works nicely. He's pain-free.
So not to take much time, but what is the youngest patient you have operated for the episealer talus?
In the talus?
Yeah.
I think we have a patient in, I think 25 years or something like that. We state that we have an optimal window of opportunity between 35 and maybe 65. We can go way up in the age. It's not really a matter of the implant not working for all people. In young people, they have a longer expected lifetime, of course, and so people may prefer alternative methods using biological means, and some do. But I think with our increasing experience now in also younger patients, I think it's it may be tolerated also in young people. So I think our youngest one is actually 25 years old.
And with your vast experience, have you come across any revision, or have you revised the 𝗱𝗍𝗁 or revised with some other surgery?
Yes, we have revisions, of course we have, but we have very few.
Okay.
And our revision rate in the knee now, with a follow-up of a decade, is in the order of 2.5%, which is extremely low. We are extremely satisfied, of course, with that. In the talus, it's really too early to talk about revision rates with this short follow-up. I am actually not sure that we have any revision so far, but the follow-up is very, very short.
Thank you so much.
So Dr. Shyam Thakkar has started his own setup called Innate Orthopaedics.
Yeah. So I
as a
learned.
senior professor and head of the Department of Orthopaedics, University of Karolinska, do you have some wisdom to share for his success?
Well, I mean, it's just to keep up the good work, aim for good results, which is self-obvious. So, and I wish you good luck. That's very good. Excellent.
Thank you so much.
Thank you so much. Yes.
Your blessings.